The following program contains images of an actual surgical procedure that may be graphic and disturbing. Parents are advised that these images may not be suitable for young children.
We have an exciting show today, starting off by going live in the OR to show you a procedure that's a groundbreaking non-surgical alternative to open heart surgery. This is a big deal, everyone.
So cool.
Yes. Very cool. And joining us now from University Hospital's Cleveland Medical Center is cardiac surgeon Dr. Joseph Sabik, interventional cardiologist Dr. Guilherme Attizzani, and advanced interventional cardiology fellow Dr. Lamar Odom, and their patient K, as well as the rest of the team. Thank you so very much for allowing us into the OR today. Can you explain to us the procedure that you're performing?
What we're going to see today is actually the replacement of a valve without opening someone's sternum, without putting them on the heart-lung machine, without stopping their heart, and without using general endotracheal anesthesia. They're going to be awake through the entire procedure. And the way this procedure is done is threading a catheter through one of the arteries in your groin called the femoral artery, and then the catheter goes through the present aortic valve that is very stenotic, and what that means is blocked. It's become calcified. And we're going to be able to deliver and place the valve that way. So again, no opening the chest, no going on the heart-lung machine, no stopping the heart, no general anesthesia.
Wow. Can you talk a little bit about the benefits of this way of replacing the aortic valve versus the open heart procedure?
So for me to do what I need to do, we have to, open a chest, put someone on the heart-lung machine and stop the heart. And patients go through a day or two in the intensive care unit afterwards, maybe 3 or 4 days in the hospital, and then a 6 to 8 week recovery time. Now we're talking about replacing someone's valve without doing any of those things, really with no incision, just a small puncture over the artery in the groin. And so the patients are spending maybe a day or two in the hospital, and then within 3 or 4 days, they're back to their normal life.
I'm sure the big challenge here, doctor, is you have a valve that's a certain size, I guess about 1 inch, but you have to pass that through a much smaller catheter. How do you do that?
You're exactly right. The technology that's involved with this is just, mind-blowing. It's all how that valve is loaded on the catheter. We call that crimping. And then when the valve is crimped and delivered through the valve, it is then allowed to enlarge and move the old valve out of the way, and the new valve sits in there very nicely.
Now, if there's someone sitting at home and they're planning to have open heart surgery, can you talk about who would be an ideal candidate for this procedure?
When we think about the universe of patients having aortic valve disease, some patients are high risk, some patients are intermediate risk, and some patients are low risk. Whenever we bring any new technology in, we want to make sure we're doing no harm. And so we tend to start these in patients who may be very high risk from surgery. We have equipoise there. And so when this technology was rolled out 6, 8 years ago or so, it was started in patients who were very sick, very high risk. And we looked at those patients and compared their outcomes with surgery and with this procedure. And this procedure was equally effective and beneficial because you didn't have the morbidity associated with surgery. Now we have studies that have shown that probably about another 20% of patients who have aortic valve disease, those with intermediate risk, are good candidates for this procedure as well. So today, we're allowed to do this in probably 20–25% of the population of aortic valve disease. And now we're doing studies looking at the majority of patients with aortic valve disease that are low-risk patients and see if this is an appropriate procedure for them. We'll know those results within the next few years. And one of the amazing things about this procedure is that many patients in the past who would not have aortic valve surgery because they were high risk or elderly and weren't candidates for surgery can have this procedure. And so today in the United States, more patients receive catheter or TAVR aortic valves than surgical aortic valves. It's really been an incredibly disruptive technology and incredibly beneficial for patients.